Hello, I'm Dr. Ki-Bum Kim from Department of Urology at Seoul National University Bundang Hospital. I would like to show my gratitude toward the KJU editorial board for giving me opportunity for this interview. I would like to introduce my research, the clinical effect of Abiraterone acetate in Korean patients with metastatic CRPC according to the androgen deprivation therapy duration. Abiraterone acetate and enzalutamide were introduced as second-line hormone therapy for patients with metastatic CRPC after treatment failure of toxic chemotherapy. In the KUGA 301 trial, abiraterone improves overall survival and quality of life in patients with advanced prostate cancer in the last 2 years. Furthermore, in the KUGA 302 trial, abiraterone improves radiographic progression-free survival in toxic-naive patients. The activity of Abiraterone according to ECOG performance status is not well described. In clinical practice, Abiraterone is usually used in ECOG performance status over 2 patients. In real clinical practice, there are insufficient clinical outcome in Asian population due to lack of clinical data using Abiraterone. In previous study, relative small ratio of ECOG performance status over 2 patients were included. Abiraterone acetate is expensive and patients who can be applied abiraterone are limited, and there was few data regarding about the clinical effect of abiraterone in patients with metastatic CRPC according to androgen deprivation therapy duration. Therefore, we analyzed the efficacy of abiraterone in terms of ADT duration. We retrospectively analyzed the medical record of patients who took abiraterone from May 2012 to March 2014 at our institution. For each patient's age, body mass index, prostate-specific antigen, number of metastatic sites, biopsy Gleason score, previous radiotherapy history, previous radical prostatectomy history, previous ADT history, and previous chemotherapy history were considered. Metastatic CRPC patients who failed docetaxel-based chemotherapy were treated with abiraterone and prednisolone. The mean ADT duration was 34.5 months. We categorized patients according to the mean ADT duration, assessed clinical outcome according to ADT duration. The duration of previous ADT was defined as time for start of first-line hormone therapy to start date of first subsequent anti-cancer treatment. Side effects were classified according to common terminology criteria for adverse events criteria. PSA doubling time was defined as the time it takes for PSA value to double from PSA nadir level. PSA progression, radiographic progression, and clinical progression were defined according to prostate-specific antigen working group 2. In addition, we analyzed the clinical outcome according to ECOG performance status. Characteristics of patients were analyzed by using Mann-Whitney U test and Fisher's extract test. Fisher's extract test also was used to analyze the stratified clinical response with abiraterone belonging to ADT duration. PSA progression, radiologic progression, and clinical progression according to stratified ADT duration were compared using the Kaplan-Meier analysis with the long-length test. The impact of various clinical pathological factors on progression-free survival were examined using Cox proportional hazard regression models. This is baseline characteristics stratified by mean ADT duration. Group A was 11 patients and Group B was 9 patients. The mean patient age for this cohort was 75.95 years, and the mean PSA was 185.82 nanogram per milliliter. The median follow-up duration was 13.4 months. There was the similar proportion of the patients undergoing radical prostatectomy or radiation therapy between the Group A and Group B. The number of metastases in each group was almost one site. The mean nadir PSA was 80.3 nanogram per milliliter in Group A. The mean nadir PSA was 41.7 nanogram per milliliter in Group B. Significant PSA decline was observed 2 patients in Group A and 5 patients in Group B. Side effects were observed 8 patients in the entire cohort and even in both groups. It's shown no statistically significant difference of outcomes stratified between patients with ADT duration. It showed no significant difference of outcomes with Abiraterone stratified between patients with ECOG performance status. In Kaplan-Meier analysis, PSA progression of group A has no significant difference compared with group B, and p-value was 0.322. As for radiologic progression, there is no significant difference between group A and group B. P-value was 0.717. As for clinical progression, there also was no significant difference between group A and group B. P-value was 0.298. In multivariable analysis, there was shown no significant difference of outcomes with Abiraterone stratified between patients with ADT duration. Although it is the retrospective small-size study, we did not observe any statistical difference in the clinical response of Abiraterone between metastatic CRPC patients with long ADT duration and those with short ADT duration in terms of progression-free survival. A large-scale, multi-center, prospective study is needed to fully evaluate the clinical effect of Abiraterone in patients with metastatic CRPC according to previous ADT duration.
To our knowledge, our study is the first to exclusively focus on the clinical effect of abiraterone acetate in Asian patients with metastatic CRPC according to the ADT duration. Duration of hormone therapy might reflect the biological prognosis of underlying prostate cancer, especially to anti-androgen therapies. In current studies, we found that the clinical response of abiraterone may be similar between mCRPC patients with long ADT duration and those with short ADT duration. We also analyzed the same way according to the ECOG performance status. Because it is a small size study, we cannot find a statistical difference between each groups. But we also found a similar pattern in previous studies. Kaplan-Meier analysis demonstrated that progression-free survival might be associated with ECOG performance status. The limitation of our study include its retrospective nature and the data from a single institution. Small size of our cohort has limited the generalizations of our studies. In the view of statistical analysis, the relative small sample size in our study could result in a weak statistical power and generate the potential bias, especially in the multivariate analysis.